Hi everyone, my name's Mariah and I'm going to be presenting a surveillance program called Community Associated MRSA Intervention, or CAMI. A brief history of MRSA. In 1960, hospital-associated MRSA became a problem and has continued to remain a problem in the United States and around the world. In 1981, the first reported case of community-associated MRSA was seen in injection drug users in Detroit. Evidence suggests that health-associated and community-associated MRSA are genetically different variants. In 1997 to 1999, 4 children died from a community-associated MRSA, 2 in Minnesota and 2 in North Dakota. Today, MRSA is the #1 cause of skin and soft tissue infections presenting to emergency departments in the United States. The public health burden. MRSA is the leading cause of death via infection in the United States. In 2005, the standardized mortality rate was 6.3 per 100,000. The current standardized incidence rate of invasive MRSA is 32 per 100,000, with males being more likely to get MRSA at 37.5 per 100,000. About 1 in every 100 people carries MRSA without getting an active infection. Primarily, MRSA colonizes in the nose. The economic burden is somewhat unclear, but is thought to be significant. One group of researchers developed an economic simulation model to quantify the annual costs of community-associated MRSA. They found that the burden on society was anywhere from $1.4 to $13.8 billion a year, and the burden on insurance companies ranged from $478 million to $2.2 billion, for a total range of anywhere from $2 to $16 billion a year. If we were able to decrease transmission and incidence of MRSA while increasing early identification and treatment, a significant amount of money could be saved. Trends. The adjusted national incidence rate is decreasing, but in unequal amounts. So the average combined healthcare associated or hospital-acquired incidence rates have decreased approximately 40% since 2005, but community-associated rates have remained relatively constant. You can see the graph. The top 2 categories are the hospital-acquired or the healthcare-associated, and those rates are going down. And the bottom, the brighter magenta, is the community-associated MRSA that has pretty much stayed the same since 2005. Risk factors for MRSA, the 5 C's: crowding, contact, usually skin-to-skin contact, compromised skin, contaminated surfaces, and lack of cleanliness. Risk factors. Common groups in which community-associated MRSA is being isolated more frequently: prisoners, daycares, students, athlete, military, pretty much anywhere where there's people crowded together in dense populations for long periods of time. There's contradicting data on racial differences. Some studies have found higher rates of MRSA in Caucasians, while others have found higher rates in African Americans. Typically, any other races are the minority of MRSA infections. But these studies have pretty much all found that males are more likely to get MRSA than females. So here we see tables of Staphylococcus aureus in general. The odds ratio in both of the tables show 1.5. So you can see here and here the odds of being a male with Staphylococcus aureus are higher than for females. Specifically for MRSA, there was a Swiss study of over 12,000 individuals that found male sex to have an odds ratio of 1.9 on a multivariate analysis. Another population-based surveillance study of data from 3 different countries that assessed 83 million person-years of infection data found the relative risk for males to be 1.72. So male gender is significantly associated with MRSA risk, but why? Probably there are multiple factors that are associated with this, but there are some gender differences in behavioral practices like hand hygiene that likely influences MRSA colonization and infection rates in males. And believe it or not, nose picking. There is a positive correlation between the self-reported frequency of nose picking and the frequency of both positive cultures and number of bacteria detected. Self-reported nose picking is higher in male college students as well. Observational studies. There have been some direct observational studies of US college campus bathrooms. I'm not sure exactly how that worked, but they placed people to observe in the restroom. These studies were done at universities in Texas, and Penn State also did this type of study. And they all found that males had a significantly lower frequency of hand hygiene, soap use, and hand washing duration. Males also had more negative attitudes about hand washing than females. Visual prompts or poster campaigns, males responded better to disgust-based messages and increasing soap use by almost 10%. There have been several other prevention or intervention programs that have targeted specifically male student athletes in the US. For example, in 2003, the USC football team experienced an outbreak with 17 out of 107 football players being diagnosed with community-associated MRSA, which led to prevention and treatment. And the following year, only 1 case of community-associated MRSA was seen. The program followed CDC guidelines for improving cleanliness, proper wound care, and not sharing sports equipment, razors, towels, etc. The objective of CAMI is to reduce the incidence of community-associated MRSA among male college students living on campus. So, Community-Associated MRSA Intervention Program, or CAMI, is a community-based prospective intervention that will target male Penn State University students living on campus at University Park. Half of the students will receive the intervention and the other half will not. And all the male students living on campus will be randomized into either the intervention group or the control group. The intervention group will be educated on the 5 C's: transmission, spread, and prevention of community-associated MRSA, and will incorporate disgust-based messages and images since they've been shown to be more impactful to the male population. Nasal MRSA detection swabs will be administered on the first day and the last day of the program. Medical records or positive lab culture results can also be obtained from medical providers if any of the participants got an active infection during the program. CAMI will be an academic year-long educational program held in on-campus student housing at University Park. There will be 12 sessions, starting off with 1 hour a week for the first 4 weeks, and then going to 1 hour per month until the end of the school year. The results in May at the end of the academic year will include nasal MRSA swabs and any medical records that show positive MRSA infection. If the length of the program is determined to be too short, for instance, if no new cases of MRSA are seen in either group. Any participants that are still living on campus the next year will be tested again. The expected outcomes. We expect to see lower incidence of MRSA in the intervention group that will show to be statistically significant due to the use of skills and knowledge learned through the program to decrease risk and spread of MRSA. We expect to see a higher incidence in the non-intervention group because they are unlikely to change their behaviors. So relative risk or odds ratio will show statistically significant differences in incidence between the intervention and the control groups. Significance level greater than 0.05 and power 0.9. The strengths of CAMI. Large sample size is more likely to be associated with causation or reliable validity of the tests or the study. It has a target population that's at greater risk. There will be significant external validity. The results of the study and intervention will be relatable to other universities. The program addresses multiple factors that increase risk of MRSA, including hand hygiene, cleanliness, and contact with skin and surfaces that may be contaminated. Also, reducing the rate in males could lead to reduced overall incidence or prevalence rates in both genders. MRSA can be accurately detected using a nasal swab PCR assay. The test has sensitivity, specificity, PPV, and NPV values that are typically above 80%. There's also a low likelihood of loss to follow-up because these are college students. We expect that there will be relatively low loss besides students who fail or drop out or transfer to different schools. We'll have a pretty consistent participant pool. Limitations of CAMI. Some studies suggest visual campaigns are less effective in males. The OR of 1.5 requires approximately 2,000 participants, so that's quite a large population to maintain. The positive nasal swab does not always mean a MRSA infection. Although MRSA colonization in the nose has been associated with increased risk, actually 7 times more likely to have a clinical infection, you can still carry the bacteria without getting an active infection. And using the nasal swab alone is likely to underestimate MRSA rates because it's only testing the nasal passages, while MRSA has been shown to also colonize the throat, genital area, and armpits. And my references. Thank you, everyone.